Good morning, everybody. We're going to start with our keynote speaker, Dr. Javed Butler, and it's my pleasure and honor to introduce Dr. Butler. He's currently the chairman of Department of Medicine at University of Mississippi, and prior to that, he was the director for the Division of Cardiovascular Medicine at Stony Brook. Before that, he had the research enterprise at Emory, essentially a well-known, renowned world leader, trained in Aga Khan University in Pakistan, after which went to Yale University, Vanderbilt, did an imaging fellowship in Mass General, has accomplished many accolades, serves on the board for the various societies, has gotten many awards, well-published, and he's been a mentor for many of heart failure cardiologists and professionals. We're honored to have him here. And chairman of medicine is a busy world, and he's in and out literally last night, and he's going to be flying out. We thank him for being here. Dr. Butler, thank you.
Well, thank you very much for the very, very kind introduction. I'll try to make it sort of really informal, so just stop me in the middle if you have questions or whatever, and we can have a dialogue. I also want to correct one thing in the introduction, which is a blatant lie that I come from a cooler place. I come from Jackson, Mississippi, so I think we're pretty comparable in terms of the competition. So changing paradigm for heart failure, I was sort of thinking about a little bit what to talk about the program, and I looked at the program agenda, and I think Dr. Pagani will talk about surgical approaches, and there were some device talks. So I just thought that maybe I'll focus primarily on drug-related talk and drug development sort of processes that I see unfolding in the future. So that will be the focus. I do have a lot of disclosures, and I'm involved with a lot of pharmaceutical companies that are developing these projects, and most of the clinical trials that I will mention in one way, shape, or form, I'm actually involved in the trial, so just keep that in mind as you hear my comments. So the main focus will be a medical therapy, and then also last month was exactly a 1 year since the passing of my mentor, and I just wanted to acknowledge Mihai Georgiadi. There is absolutely no single person who has had a more significant impact on my career than Mihai. So just wanted to give a shout out to Mihai. So before we try to figure out where we are going with heart failure, with again a lens of medical therapy, let's try to figure out where we are right now. So this is the evolution of development of therapies for heart failure, medical therapy over the years. It started with VA, the VHEF study. Many of you may or may not know that the way we think about a multi-center trial, now it's part of our lingo, and we just do it all the time, and these are multi-center trials with central adjudication and inclusion-exclusion criteria, which are broadly applied to different institutions and all that kind of stuff. This was actually not the standard how we generated evidence. Most of it was single-center, sort of, some expert did the study and told us what to do. So VHEF was the first really large multi-center trial, the way we think about multi-center trials. So again, I want to take some credit for the heart failure field that all the multi-center trials all across medicine that we see started with the VHEF trial. And anyway, so this is the evolution, and this evolution has now culminated into the Paragon HF trial, as we know, with valsartan sacubitril, sort of a big win. Remember that there is one word missing on this slide, which we see with almost every other slide, which is the word placebo. So there was no placebo. This was an active control. So you're sort of taking the king of heart failure, which is ACE inhibitors. And against the standard of care, you showed an additional 20% relative risk reduction for morbidity, mortality, cardiovascular mortality, and heart failure hospitalization. So all that is really good news. The bad news is that despite of this care, so let's think about Paradigm HF trial in a way. Like most clinical trials, you get rid of all the patients with severe comorbidities and end-stage renal disease and end-stage COPD and whatnot. I mean, that's sort of standard. Patient population tended to be a little bit younger. And then the baseline medical therapy was very, very good. Not only 90+% were on beta blockers and whatever 40-50% were on MRA and all that kind of stuff that goes on in clinical trial, which may or may not happen in real life practice. Because you were comparing it against enalapril, it was important for enalapril to be given at higher doses. So the average dose of enalapril in this trial was 18.8 milligram, which is nowhere near what happens in real life, where people are hanging around 5 milligrams or so enalapril dose. So despite of the fact that this very well-treated group of patients, and on top of that, valsartan sacubitril lowered 20% relative risk reduction, if you actually not worry about the relative risk reduction, and if you look at the absolute risk for these patients at 1 year, you're still looking at about 10-12% risk. And also remember, this is not an in-hospital class 3 kind of patient. This is outpatient, stable patient, and about 70% had class 2 heart failure. Now, what's interesting is the way our mindset is about heart failure, and I'll talk about this again in a few minutes. Because we used to have, after the diagnosis of heart failure, a 30% 1-year mortality, and now we are down to, in stable class 2 patient, 8-9% mortality, 12-13% combined mortality, heart failure hospitalization rate. We just think that we have sort of won this battle. This is the same false mindset we have about smoking in the US, right? We just say, well, now we have done such a big dent in smoking. Remember, still about 1 in 5 Americans smoke. The smoking percentage for the US population, adult population, is about 18%. So we are nowhere close to being done. But again, coming back to this heart failure issue, it's very interesting that what is the risk of dying after myocardial infarction or after stroke? Just all comers if you take it. It's about 5-7%. And, that risk we take very seriously. But here, when we talk about a 10% risk, we just don't take it very seriously. So just park that thought in your mind, and we'll come back to that thought in a second. So that's about where we are at HFrEF. Yes, a lot of advances, but still a lot of residual risk. What about HFpEF? So again, many studies showing that the risk for mortality, hospitalization, and deterioration in quality of life, functional capacity, pretty comparable in HFrEF and HFpEF patients. And as we know, there's no known therapy approved for long-term reduction in mortality for patients with heart failure with preserved ejection fraction. And this is the group with aging of the US population is actually growing. There are already data that suggest that of all the hospitalizations for heart failure, HFpEF have already exceeded HFrEF. And overall proportions are going to probably be more than 50%. And this is the second slide that I want to emphasize this point. I can bet you that in an incredibly sophisticated medical center like this, if you were to go out and talk to your residents and fellows and nurses and internal medicine staff and whatnot, and just ask them that you're not talking about cardiogenic shock, LVAD, transplant, all that kind of high-tech stuff. Just look at run-of-the-mill patient who comes in with heart failure. There are 1 million hospitalizations in the US with the primary discharge diagnosis of heart failure. There are additional 2 million where heart failure is a contributory diagnosis. So 1 million hospitalizations with primary discharge diagnosis. The average length of stay in the US is about 4.5 days. We give them diuretics, they pee, they feel better, we discharge them, they look good, we take care of whatever their AFib, UTI, whatever we have to take care of. I just ask them, what is the risk of dying within 1 year of discharge? Remember, we already set the benchmark for myocardial infarction, stroke, 7, 8, 9%. What is the risk of dying from this routine 4.5-day hospitalization? They diuresis, they go home. I can bet you that you won't find 1 in 10% of the people that will tell you that this person has a 1 in 3 chance of not being with us at the end of 1 year. 30% 1-year mortality. I mean, it's unbelievable, but this is just not the way we think about decompensated heart failure hospitalization. I mean, the way I sort of think about it is that if somebody comes in with pneumonia and has fever, rigors, chills, and you give them Tylenol, the fever goes away and you discharge them. That's what we do with acute heart failure. We give them Lasix, which is the Tylenol of acute heart failure. They pee, their symptoms get better. We have done nothing fundamentally to the biology of the disease, and the biology is worsening, and they have a 1 in 3 chance of dying. So where are we in 2019? No known therapy for HFpEF, which currently is half of the heart failure population, is the growing segment. No known therapy for acute heart failure, which is by far the largest cost driver for healthcare in general and for heart failure certainly. And there are several known therapies for HFrEF, but there is a large residual risk. So our work is cut out for us, and there is a lot more work that needs to be done. And there are reasons to be happy, and there are reasons not to be happy either. So what's going on in the clinical trial world and sort of what is around the corner? So HFrEF continues to be a pretty robust space. There's a lot of phase 2 clinical trials going on, and hopefully we will see more data coming out. But the big two right now that are going on, one is affecting the nitric oxide soluble guanylate cyclase cGMP pathway. So as you know, the cGMP pathway is really ubiquitous. So it's in the skeletal muscles, it's in the kidney, it's in the heart, it's related to the energetics, it's related to the endothelial function. So if you can positively affect the nitric oxide signal, at least theoretically, it holds promise that it will improve not only heart cardiovascular outcomes because of cardiovascular benefit, which is heart and the blood vessels, but possibly also liver and the skeletal muscle, maybe improve exercise capacity. So a lot of promise here. But remember, we have to be a little bit cautious in this promise because we have been trying to work on this pathway for quite some time, and we really haven't succeeded. You give the the sublingual nitrate that we take. I mean, that's nitric oxide donor. The only problem is that you develop tolerance to it pretty fast. And then in the presence of oxidative stress, which is present in patients with heart failure, that nitric oxide is shunted to peroxynitrate pathway and actually becomes toxic. So just giving nitrates have not worked per se. You can stop the degradation of cGMP pathway by giving phosphodiesterase inhibitors. There was going to be a large trial, but it sort of never happened. But theoretically, at least to me, it does not make a lot of sense because the issue is less production. There is, to my knowledge, no data that has suggested overexpression of phosphodiesterase pathway. If overexpression of phosphodiesterase pathway and degradation of NO cGMP signaling was the problem, then blocking the degradation makes sense. The problem is upstream, that you're not just producing enough, and therefore whether or not it will work, I don't know, but we don't have the trop. The beauty of these molecules, the SGC stimulators, is that they actually work directly independent of the NO coming from the top. So they actually stimulate the soluble guanylate cyclase to develop cGMP, which then has all the downside signaling benefit. So theoretically, it's a very attractive drug that can potentially benefit. And we did do a phase 2 study. Socrates reduced, and as you can see, there was a dose-dependent reduction in NT-proBNP levels. There was some hint that there was remodeling got better with ejection fraction. And then again, I mean, I don't know what to make of clinical outcomes in a small phase 2 trials, but nevertheless, things were going in the right direction. And at higher doses, everything was getting better. And that has led to this large trial called Victoria trial, comparing 10 milligram of vericiguat with placebo. Remember, a cousin of this, riociguat, is already approved and in the market. It's a multiple times a day drug for pulmonary hypertension, and now vericiguat is being evaluated. So as of 2 weeks ago, the trial is completely enrolled. It's about 4,500 patients, and we will hopefully get the result in the next year or so. So that is one thing which is interesting. And then the other thing which is interesting is omecamtiv mecarbil. It's a myosin activator, so it increases cardiac contractility. So I am very excited about this molecule, and the reason I'm excited is that if you think about it, if you had an injury to the heart, some sort of injury, and your ejection fraction goes down, whatever it's chemotherapy induced or myocardial infarction or whatever, theoretically speaking, if your EF used to be 60% and now it's 40%, it should remain at 40% until there is another insult for it to go down. But we all know that doesn't happen, and that doesn't happen. If you leave that patient alone, that 40 will become 38, 34, 36, it will continue to go down. And that's because of the secondary neurohormonal activation when you have low ejection fraction. So theoretically speaking, this downward spiral of neurohormonal activation on the basis of which we give all these neurohormonal therapies can be mitigated, can be attenuated if you have something which increases cardiac contractility. And if you increase cardiac contractility, you don't have as much reason for neurohormonal activation, and you may not actually need all of these other therapies, which we have found difficult related to dose and whatnot. And we know from a lot of data that inotropes work great and make people feel better, and their shortness of breath get better, and they pee more, and their creatinine gets better, and they walk. The issue is sudden cardiac death, because they all work through the cyclic AMP pathway, and with the cyclic AMP pathway, you increase intracytosolic calcium concentration, and you increases the risk of sudden cardiac death. This works in a different mechanism, and it optimizes the actin-myosin head interaction. It increases that duration, so the cardiac systole, or the systolic ejection time, increases, and therefore it does not have any direct effect on intracytosolic calcium concentration. So that's another, there's both IV and oral formulation, increases cardiac output, fractional shortening, and stroke volume. And on the basis of that, there is the largest trial ever to be done in HFrEF space, Galactic HF, going on over 8,000 patients. I don't know whether this is larger than Paradigm or not, but they're probably neck to neck. One issue with this is that, so one issue is sudden cardiac death. So anything which is, although this is not technically an inotrope the way we think about an inotrope, and there's no theoretical reason to believe the risk of sudden cardiac death. But again, there is this issue of inotropes that we have to worry about with sudden cardiac death. So we'll see what the data shows. The second issue is that there's a troponin leak. So now, if you look at all the drugs, troponin for heart failure is the biggest safety marker that we have. The thing is that we have not had any example up until now where troponin and NT-proBNP go in the opposite direction. If things are going well, troponin and NT-proBNP levels both go down. If things are not going well, they both go up. This is the only drug where we have a crisscross signal that the NT-proBNP levels go up, but there's a little bit of a troponin leak with the agent, which is an inotrope. So the question is, if the clinical outcomes get better, but there's a little bit of a troponin leak, how do you interpret those data? So obviously, this will be looked at very, very carefully. In the phase 2 studies, there was a troponin leak which was seen. However, it did not translate into worse outcome, and then actually there were improved outcomes, and that's why we're doing this 8,000 patient study. So a little bit of a nuance, but an interesting nuance to watch for. What about, so these are sort of the two big programs going on. There are other smaller programs going on. But in the interest of time, the question is that this is how we have been thinking about HFrEF. The question is, how should we be evolving our thought process related to that? And that is, we have written a lot about it, that we need to sort of fundamentally think a little bit different about heart failure. And this will be a long road, and I don't know whether in the rest of the leftover career that I have that we will get to that point, but we will certainly not get to that point if we never start. So if your car is not working and you take it to the mechanic, right, and if the mechanic kind of looks at the tire and looks at the ignition switch and looks at the trunk and whatnot, but never opens the engine to try to figure out what's wrong with the engine, you all will sort of lose faith in that mechanic a little bit. Well, that's what we're doing with heart failure, right? We have neurohormonal antagonist and kidney and comorbidity and this, that, the other, and sort of nobody is looking at the heart as to what is the problem with the heart. And again, as I said, it's not going to be easy. So there are energetic issues, there are mitochondrial issues, there are actin, myosin, both concentration and activity issues. There is calcium handling issues. There are sort of a whole bunch of issues that are going on the myocyte. That's the bad news. The good news is that there's a fundamental difference in heart failure with reduced ejection fraction and other end-stage organ diseases. How do you define a staging of cirrhosis? You take a biopsy and find out how much fibrosis is there. The parenchyma of liver is gone, it's fibrosis. How do you take a biopsy in somebody with advanced COPD, what do you find? You find fibrosis. You take somebody with advanced heart failure, you actually don't find as much fibrosis. Yes, of course there are some cases, and if you look at the LVAD core and really end-stage dying patient, there will be fibrosis, but there are very good MRI studies that basically, and other microscopic studies also, that if you look at patients with a lot of heart failure, the overall fibrosis burden is actually pretty little. But if you look at the myocytes under the microscope, what you basically see is that your actin myosin content is significantly downgraded. You have these like little bitty small mitochondria, and there's a lot of dysfunction. But your cell membrane is intact. This is a poor, hibernating, non-contractile, but viable, alive myocardium, which gives us a lot of opportunity that if we had the right kind of therapies, we can regenerate the myocardium and we can actually improve the cardiac function. So in those advanced cases where there's a lot of cell death and there's a lot of fibrosis, that's a different story. But by and large, most of the patients, if you look at a 15-segment model on echo or MRI or whatever, and you look at these patients with EF of 20, 25, 30%, most of the, so there are segments which are contracting, they are contracting, but most of the segments which are non-contractile either have no fibrosis or their fibrosis is limited to less than 50% of the wall thickness. In other words, there's still a lot of viable but dysfunctional myocardium left that we can improve. And I think the paradigm shift moving forward will be that we will develop a lot more therapies which are focused at repairing the heart itself rather than doing these peripheral things. A part of the reason why also this has become important is that we got to develop therapies that are hemodynamically neutral. We just cannot lower people's blood pressure anymore. I mean, every drug we have lowers people's blood pressure, and they're already sort of dizzy and hanging around in 92. And most of these other drugs that I'm talking about that have cellular repair properties are actually hemodynamically neutral, which increases the hope that they will work a little bit better. So if you invite me back to this seminar to give a talk in about 25 years, I may have some new therapies that are repairing the heart, but I don't think that it's going to happen in 5 years. And again, just to give you an idea about the mitochondrial dysfunction and why it holds a lot of promise, both in terms of the cardiac energetics, but also in terms of multi-organ benefit at all. I have no idea what to say about stem cell therapy. I mean, you know, my worry is that, you know, the scientists get a little bit too excited about what they're doing, and therefore they tend to just a little bit overpromise. So the only problem with overpromise is that we completely lose faith of the population, because we just overpromise and this is going to happen, and then nothing happens, and then the population pushes back. So these stem cells are going to be some Star Trek sci-fi. You're going to inject it, and they're going to replace all the cells and start contracting. And obviously, nothing has happened. You know, what worries me is that we are doing exactly, we did that with gene therapy without understanding the biology, and now we're doing the same thing with the buzzword personalized medicine and all that kind of stuff. So I think, I mean, it takes some time. The problem with the stem cell therapy is that we don't know which is the ideal route. We don't know how many repeated injections we have to give. We don't know which stem cell preparation is the best. And we don't know the dose. I mean, we really don't know these fundamental things. What we do know for a fact that the effect is largely paracrine. There is no replacement of the heart muscle. You inject these cells, you have radio tag. In a month, you look back at the heart, all of those cells are gone. So whatever the effect is, it's going to be because of the paracrine effect, not that it is replacing the heart. So there's a lot of work to be done. I'm optimistic about science. I'm not optimistic about this being a viable therapy in a very short time frame. So quickly moving on to HFpEF. This trial is a little bit, this slide is a little bit thinner than HFrEF. There was a lot of trials and a lot of positive trials. Here there are fewer trials and no positive trials. Most of you will probably know this whole debacle about TopCat trial with spironolactone. This trial overall was a negative trial, did not reach its primary endpoint, but there was a lot of regional variation. And basically, if you look at the Americas, spironolactone achieved a statistically significant p-value with a reduction in cardiovascular death and mortality in patients with heart failure preserved ejection fraction. And it kind of makes sense because spironolactone affects aldosterone function. Aldosterone affects fibrosis. These are older people. They are thick, stiffened heart. It would make sense. However, if you take Russia and Georgia, Republic of Georgia, not Atlanta, Georgia, if you take Russia and Georgia and put them together, they accounted for about a third of the enrollment in this trial. This trial was done with your money. This was an NIH-sponsored taxpayer money, but we could not enroll patients in the US, so was farmed out. And that those third patients had absolutely no benefits. If you put everything together, nothing was proven. So, all of us should have the first reaction, which should be pretty critical to say, well, you know what, a trial is a trial is a trial. You cannot just look at the subgroup to try to make your point. You did the trial and the trial is negative. The problem is that in general that is true, but there are certain things about this trial which are so peculiar that you're just forced to look at the regional differences. And the number one thing is that look at the placebo line in the Russia and Georgia population. These heart failure patients in Russia are practically immortal. Like nothing is happening to them, right? I mean, if you look at the absolute event rate, there's nothing going on. I mean, if the event rate was truly this in a heart failure patient, we should not even have this summit. So the problem is, the question comes up, did these patients really have heart failure? So if you then start digging into some more characteristics, you kind of just start questioning what were these patients that were being enrolled in these patients. Remember that when pharmaceutical companies do these trials, they have a budget of $400 or $500 million, and there's a lot of oversight of the sites. The NIH trials are whatever, $50, $60 million, and there's close to no oversight, and it's sort of a honor system, and sometimes it doesn't work out. But then the other thing is that in the arm that supposedly got spironolactone, there was no bump in creatinine, there was no bump in potassium, and then finally, remember that spironolactone is a prodrug. It goes into the blood and gets converted into canrinoate. So if you look at the serum canrinoate levels, in third of the patient, there were no canrinoate levels either on people supposedly on spironolactone. So we don't have a good enough answer to make it a guideline class 1 recommendation. If you talk to most of the heart failure people, they've kind of bought into the idea that spironolactone works in HFpEF, but there are 2 more trials going on right now, one in Germany and one in Sweden, readdressing this question, and we will get some answers there. And then the Paragon trial is ongoing based on the data from the Paramount trial. So this is, again, valsartan sacubitril that we saw in Paradigm HF in HFrEF. Reduces left atrial remodeling. Again, if you had a concentrated talk with a heart failure expert, most of them will say that HFrEF is a disease of the ventricle, whereas HFpEF, if you look at the hearts of people with hypertensive heart disease and HFpEF, their ventricles are no different. It's the same distribution of left ventricular hypertrophy, same distribution of diastolic dysfunction. What is different is that patients with HFpEF have larger dysfunctional atria. So as far as your atria can keep absorbing the pressure from the bottom, your hypertensive heart disease. When the atria fails, the fluid backs up. So one theory is that HFpEF is actually an atrial disease. Another theory, which I believe in a little bit more than that, is that HFpEF is not even a heart disease, it's a kidney disease. And that's a whole separate discussion that we can have some other time. Bottom line is that in the Paramount HF trial, as compared to valsartan with Entresto, valsartan sacubitril, there was left atrial remodeling, and there was reduction in NT-proBNP, and then the Paragon HF trial was conducted. So like Victoria, this is another large trial which has completed enrollment, and we should be getting the data within a year. And if this trial is positive, this will be the first trial ever to be positive in HFpEF patients. And then a lot of us have sort of talked a lot about how to develop drugs in patients with heart failure, preserved ejection fraction, and the fundamental issue here is that patients with heart failure reduced ejection fraction, about 80% of them die because of only 2 reasons: sudden cardiac death, progressive pump failure. And the pathogenesis of sudden cardiac death and progressive pump failure is the same. So there's so much convergence of outcomes that you can actually develop drugs that can target those mechanisms and expect to reduce mortality. The problem with HFpEF is that 40–50% of the mortality is non-cardiovascular, and those with cardiovascular, it's a much broader array looking at vascular disease and MI and stroke and all that kind of stuff. So there's no unifying reason because of which people are dying, so it's been tough to develop drugs that reduce mortality. Having said that, these patients are older patients, a lot of competing causes of death, but they're still very symptomatic and they're very short of breath. we have raised the bar for drug development for heart failure so high that nothing is approved and nothing comes to the market unless and until it reduces mortality and hospitalization. Well, that's not how we practice medicine. We don't give PPIs for gastritis to improve survival. We don't give some NSAIDs for arthritis to improve survival, right? I mean, quality of life and symptom improvement is a valid reason why we treat patients. So why are we not developing therapies in HFpEF that even if it doesn't improve survival, can at least make people live longer, live better, and improve their quality of life, even if you cannot improve their length of life. So I have spent tremendous amount of time, like many other colleagues of myself, working with industry, working with the FDA to try to get to the point where this is an accepted thing. And I'm really happy to say that there are 2 trials now going on, Vitality with vericiguat and HFpEF, and Imperial Ref and Imperial PEF, 2 trials with empagliflozin and heart failure reduced and preserved ejection fraction, where the primary endpoint of the trial in Vitality is PLS, the physical limitation score of KCCQ, so it's a subdomain of quality of life, physical limitation score, and the primary endpoint in Imperial is 6-minute walk test, with the idea that if these trials are positive and there is no harm signal, the regulatory agencies will start giving indication for symptomatic improvement, and those drugs could be available to our patients. So there's a lot of sort of work that has gone into getting to this point. Now we just need to get a positive trial, and I don't know whether we'll get a positive trial or not, but at least that groundwork has been laid. So where should we be going? So one thing about HFpEF that sort of bothers me a little bit is that the way we adjudicate cases in clinical trials, at the end of the clinical trial, when you say there was a reduction in heart failure death or reduction in certain cardiac death or whatnot, there's a blinded adjudication committee of experts who sit around, and we get on the phone, and there are 7, 8 of us, and these are painfully long meetings. Most of them, people are busy, so they are usually 7 to 10 at night. So you have your colleague who's disagreeing with you, and you have your spouse who's angry at you, and you just keep discussing cases after cases about what it is. But those criteria that were developed for this adjudication were all developed for HFrEF, and we are just retroactively fitting it in HFpEF. So we come out with the same numbers, which to me makes no sense. Like, can somebody explain to me what is progressive pump failure in a person with HFpEF? What does even conceptually does it mean, progressive pump failure in patients whose EF is 60%? Is it RV failure? Is it multi-organ disease with renal failure? I mean, I don't know what it means. Similarly, certain cardiac death, we have very good data to suggest that by far certain cardiac death in patients with HFrEF is arrhythmias. The largest proportion is ventricular arrhythmias, few are Brady arrhythmias, and all other forms of certain cardiac death is very rare. We don't have those databases. We don't have that understanding for HFpEF. I don't know certain cardiac death in HFpEF, whether it is embolic, whether it is aortic, whether it is very much like HFrEF. I don't know what it is. So again, if we don't understand why these people die and we don't understand these basic mechanisms, it becomes a little bit difficult to try to develop drugs. So I think we need to sort of understand those things a little bit better. And the other thing is that one fundamental difference between HF and HFrEF is that you can have 100 different things causing HFrEF. Ischemia, viruses, chemotherapy, genetics, whatever it is. But once you develop HFrEF, your pathophysiology funnels into neurohormonal and activation. So everything funnels down. In HFpEF, that's not the issue. The issue is not that all the pathophysiologies, actually all the pathophysiologies by themselves determine the patient's outcome. So this whole thing about having one drug covers the entire HFpEF, I'm skeptical whether this is going to totally work or not. And I think, in this day and age of sort of plethora of data that we have, we have been trying for the past 15, 20 years to do classic science and HFpEF and to come up with pathophysiology hypothesis and then try to judge that hypothesis. And the bottom line is that it's not working. We haven't gotten anywhere. So now with all the technology that we have, rather than the classic paradigm, there's a chance that we can retroactively fit and try to understand the phenotypes within HFpEF. So we obviously have omics data, which is very, very expansive. So we have genomics and proteomics and lipidomics and metabolomics and all that kind of stuff. We have imaging data, we have clinical data, we have biomarker data. And the question is, can you put all of these things together to try to phenotype people with different prognosis, different groups, and then look at their pathophysiology back ways and try to find out what is wrong with that patient and developing drugs. So again, if you get me back in 25 years, I can guarantee you we will be there. But that is the path and the journey that we have started looking at it in this way. And we actually just are completing a similar grant we got from the NIH looking at diastolic dysfunction in HIV patient with this approach as well. So a lot of work that is being done in that sense. I have 10 minutes, so I'm going to start speaking really fast, and you'll say, well, you already have been speaking pretty fast. So, and then we will just abruptly stop, so I don't have to go through all the slides. So what is around the corner? So acute heart failure. I'm trying to give you the progress of where we are. So what is the progress for acute heart failure? So some of you may be Pink Panther fans, and I love this sort of quote where Clouseau, whatever his title was, Clouseau was asked by, comes to some case and started, can you bring me up to date what's going on in this case? And this was the quote. Let me bring you up to speed. We know nothing. Now you're up to speed. So that's where we are in acute heart failure. Here is sort of the issue. You can have these, 30% mortality people coming into the hospital, all that kind of stuff. You can kind of divvy it up, People come to the emergency room. We're trying to figure out whether they have ischemia, UTI, COPD, heart failure, whatever. Then we start diuresing them. Then they start making discharge planning, and then they go home, and bad things happen to them. The problem is that in-hospital mortality is not a problem. I mean, the in-hospital mortality is like 1.5, 1.82%. Again, I'm not talking about the cardiogenic shocks of the world. I'm just talking about the vast majority of people that come in. And length of stay is 4.5 days. So that's not the problem. The problem is here that people get readmitted and people die after discharge. So the problem is here. And guess where do we do clinical trials? All the clinical trials are done here because we are looking for the magic that we will give some drip for 2 days and it will cure patients and we won't continue the therapy, which just makes absolutely no sense. And now we have more trials that have been negative. There are gazillions of trials that are negative. And now the serelexin trial and the trial with serelexin, and what's the other trial that was negative? Okay, whatever, another trial was negative. So the bottom line is that we keep doing trials and the trials are negative and they turn out to be positive. So why are we following this sort of completely seemingly nonsensical way of developing drugs that the problem is here and we just want to give 2 days of IV therapy for a chronic disease which is not a biologic. It's not like we're changing the biology. And the reason for this is that symptomatic improvement in acute heart failure is an FDA approvable indication. So everybody wants to go to the perception of low-hanging fruit, not low-hanging fruit, perception of low-hanging fruit. Now, if we lived in this world that these patients were short of breath and they were dyspneic and their dyspnea was not getting better, and if you can give the therapy and their dyspnea improves, that's a great win. The problem is that this is not acute heart failure. This is the acute heart failure of 1980s when people came in with flash pulmonary edema because of hypertensive crisis. If your hospital is anything like Mississippi, and I wouldn't be surprised, I mean, these are the patients with decompensated heart failure, 3+ edema, who are eating burgers, watching TV. I mean, that dyspnea is not as much of an issue as much as it's exertional dyspnea. And the other thing is that Lasix works great. You give them a couple of shots of Lasix and their shortness of breath goes up. So this is the reality. This is what you're competing with is IV furosemide, which in most cases works actually pretty well. And how are you going to improve dyspnea in a person who doesn't have dyspnea, who gets diuretics? It's very difficult to do. And therefore, no matter how many trials you do, you cannot beat dyspnea scores because people are not dyspneic. But the industry has this false sense that if we were to just give this drug for 2 days and improve the dyspnea, the drug will come into the market. And we obviously have a little bit of a not good history with what we did with Naziritide, and that sort of led to all of this dynamic. Nevertheless, there's one trial going on, Cardiogenic, right now. To my knowledge, this is the last trial which is still trying to have this acute infusion for 1 or 2 days and will improve outcome. There is still a theory out there that if you give very potent therapies up front, then you decrease renal injury, you decrease troponin release, and that may translate into improved outcomes. And I will be delighted if something works out. But biologically, I'm just a little bit concerned whether or not it will do that. But acute heart failure is sort of full of problems. Part of the problem is papers like this. So this is a classic paper. I pulled a paper from 20 years ago because I didn't want to have a latest paper because you just never know who's in the audience and it's their friend who wrote the paper. But if it's a 20-year-old paper, the likelihood is that nobody knows this person. But there are papers like this all over the place where we have completely dumbed down heart failure, right? So the problem with papers like this is that says that 50% of heart failure hospitalizations is because of non-compliance, right? So we can't fix you, so we're just going to blame our patients that, oh, it's a bad patient, non-compliance, and that's related to all the heart failure. The problem with this paradigm is that when we make things like this and we publish papers like this, the regulators and the insurance companies read this and they love it. Because now, well, the doctors are not taking care of and the nurses are not taking care of the compliance problem. If they could only take care of the compliance adherence problem, boom, 50% of the hospitalizations will go away. The cost will come down, and then you have the CMS rule where recurrent hospitalization is your problem, so you get financially dinged. And that's a whole sort of things going on outside right now about what is the impact of mortality. Now, if you're like any other academic medical center, how do you get these data? The way you get these data is that you go to the rounds with the patient, you have the doctor, and then you have fellows, and you have a bunch of residents and a bunch of nurses, and you hover around the patient's bed. The poor patient is like laying down. There are like 15 heads looking at the patient, and you beat the confession out of the patient. Did you eat the pizza? Did you eat the pizza? Did you eat the pizza? And the patient says, yeah, I had a slice of pizza. And you run to your chart and you say, patient had pizza, non-compliant. Now, what is the problem with that? One is that if the patient is resilient and said that I did not have the slice of pizza, you'll never go and write in the chart that no non-compliance, right? You will never do that. There is recollection bias, there is documentation bias, and the biggest thing is that we don't know the attributable fraction of non-compliance. Now, I don't want to lose all credibility with this audience where you can say, well, there's this heart failure expert that came and he just said it doesn't matter whether you take your medicines or not, and it doesn't matter what diet you eat. That's not what I'm saying. Of course, if you stop taking drugs, you'll run into a problem. Of course, if you go into a drinking binge, you'll run into a problem. That's not what I'm saying. I'm just saying that, you know, I missed my medicine for 2 days because the prescription ran out and I got it on Wednesday rather than Monday. Oh, you know, I went out with my friends and I had a beer. That kind of episodic thing, you know, how much of that is leading to this 50% non-compliant readmission? Well, the only way to find those data are to compare it to outpatients who are not hospitalized, who also missed their medication for 2 days or who also had a slice of pizza. And guess what? It is no different. If you look at the outpatient population, they are completely non-compliant. All these patients that are coming to tell you that they're totally compliant, they're not. So this issue of compliance leading to and blaming the patient is, I think, a real problem, and we have to get over it. The other thing is, so it's 8:39 and it says 2:43. I'm going to take my full 6 minutes. Okay. Is this whole issue of the vulnerable phase. I mean, that's another problem. So this is a paper by Scott Solomon, you know, Mark Pfeffer, good friends. And they basically said that the highest risk of dying is immediate post-discharge, and over time, the risk goes down for these patients, right? So we have perverted this paper into completely thinking differently about what acute heart failure is. And we just say, well, all the risk is immediately post-discharge in the so-called vulnerable phase. And if only you could tie the patient through the next few weeks or months, then the vulnerable phase is over and then you become chronic heart failure again. Now tie this to the previous slide with non-compliance. This again gives fodder to the insurance companies and to CMS to say, well, if you could just cover 3 months post-discharge, all the problem with heart failure is gone, and then you become a chronic heart failure. So what this paradigm supposes is that if the patient is resilient and said that I did not have the slice of pizza, you'll never go and write in the chart that no non-compliance. is that you have a chronic heart failure, pre-admission, all of these things kind of get worse. You come into the hospital red hot, we fix a few things, and this is sort of the vulnerable phase, and if you could just manage the patient in this phase, you become chronic heart failure again. What this assumes is that at the time of discharge, you have a uniform red hot risk, and that risk goes over time. So we sort of challenge this notion, saying that this is nothing but a statistical misunderstanding of the data. And the hypothesis that we proved that I thought, so this is another very interesting thing. You know, the study that I'm going to show you now, when I saw the result, I was so incredibly happy, and I'm like, JAMA, here we come. I mean, this is like, you know, we have figured out the truth here with the big T. The lesson I learned from this paper is that you can never challenge faith with data. It's not going to work. Nobody will believe you, because if they believe in something, data is not going to change their mind. So we went from JAMA, Circulation, JACC, European Heart Journal, to heart failure journals, JACC Heart Failure, Circ Heart Failure, European Journal of Heart Failure. Everybody rejected the paper. So even the heart failure individuals did not buy the story. And then eventually, thank God for Bill Roberts, the paper got published in American Journal of Cardiology after like 2 years or something like that. So with that introduction, you're like, why are you even showing the slides if nobody believes in it? But I will still show you that at least I'll try to convince somebody. So if this paradigm were to be true, then yes, we have a vulnerable phase. The problem is that this is not true. Patients who come into the hospital at the time of discharge, we hypothesize, had infinite range of risk. You had this person who should have been dead in the hospital. Came in with cardiogenic shock, the kidneys don't work, the heart don't work, nothing works. But somehow we came to Methodist, and you have really good doctors, and the person didn't die, and the person went to a nursing home. And then this is a person who has almost zero risk. I don't know why he came to the ER. His doctors were not available. The ER physician had a bad attitude, and they just admitted the patient. There was just no reason to come in, right? So a huge variation in risk. The way you do these statistical analysis is that you pool the risk of the whole group, and you say that this is the average risk of this population. And then this average risk, you see what happens to these patients based on this risk projection. The problem is that there is differential attribution. Attrition. The infinitely high-risk person is going to die. The infinitely low-risk patient is not going to die. So what's going to happen is that your average risk score at this point over time is not going to remain the same. So once these high-risk patients die, over time, the average risks go down if you were to calculate. But nobody does that. Nobody calculates risks over time. They still peg it to the risk at the time of discharge. So what they say is that, well, your risk of dying should be this, but your risk actually goes down, and therefore this delta in expected to observe is the vulnerable phase. This is not a vulnerable phase. The sick patients are dead, and the non-sick patients are not dead. So we looked at this in the Everest trial, about 4,000 patients with HFrEF, and look at this. So this is the Multicenter international trial, 4,000 patients, right? This is not sort of some home-cooked data from Mississippi. So here, look at, this is a log scale. Look at the variation in risk for these patients. And of course, I can average everybody's risk out, right? But if you now put the patients in a quintiles of risk, so risk of dying 0 to 20, 20 to 40, 60, 80, and 100. First of all, yes, there is a vulnerable phase, but like we're talking about 2-3% difference. The highest risk group, there is actually no difference, and for all practical purposes, this is a flat line. Sick patients come in, they leave sick, they die. Not sick patients come in, they're not sick, and they don't die. It's as simple as that. Now, if you buy this theory, then this whole issue of vulnerable phase, 7-day follow-up, all that kind of stuff is nevertheless important, but not as important. It goes back to you got to treat the biology of the disease. You got to treat the biology. Don't expect 2 days of some IV drip and 1 7-day phone call to do the miracle. You got to treat the biology of the disease. So we are trying to push this whole concept of worsening heart failure as a disease entity and not as an episodic entity. I always put this slide up because I just sort of love seeing my name next to Dr. Brownwald. But the whole idea is that it's a chronic disease and you're not going to fix it by a short-term thing. So I'll just kind of move on. So, Pioneer HF just came out. Great idea to give these drugs chronically, and for the first time we proved, rather than giving a 2-day therapy, if you start a potent therapy in the hospital, but follow it chronically to affect the biology of the disease. I mean, talk about impressive results. This is in 8 weeks post-discharge, 8 weeks, cutting out the readmission by almost half. And then this is a paper that's going to be coming out in circulation pretty soon of the signal that we're seeing with SGLT2 inhibitors. So I've run out of time, so I'm not going to talk a lot about the diabetes story. There's a great story developing there. All I can say is that there's a meeting coming up at the FDA to try to talk about prevention of heart failure. We don't talk enough, and there's a long story there with SGLT2. And then there's a lot of trials going on with SGLT2 in both HFrEF and HFpEF. The beauty of these trials are that if you look at the pharmacodynamic effect of SGLT2 inhibitors, it has actually nothing to do with diabetes and nothing to do with glucose. So the patients that are being enrolled in these trials are all heart failure patients, and about half of them are actually non-diabetic patients. So we will get some really good results there. Lots of ongoing studies. The other thing we need to do is to look at innovation in clinical trial design. We just cannot continue to do $500 million trials, so a lot of work that is going on in innovation in clinical trial design itself. If somebody is truly interested in drug development process, and again, I'm sort of shamelessly plugging myself in, if you just read this 2-page thing in JAMA, you'll get the entire landscape of what is the problems with drug development process. You won't find the entire landscape or how to fix it, but you'll at least understand in 2 pages what the problems are. And then lastly is that we cannot keep developing potent therapies and not use them. I don't know what is sort of the mindset of my academic colleagues, but implementation science becomes really important, that we have to use these therapies for the patients to benefit. So there's a lot of implementation science going on. If you look at this is my last slide. If you look at the data that is coming out from latest registries, less than 5% of the patients are on therapeutic doses of all 3 classes of drug, RAS inhibitors, beta blocker, and MRA. Less than a third are taking all 3 drugs, period, regardless of the dose. We always blame, the patient's blood pressure is low. So we just published this month in JACC Heart Failure that HFrEF patients with blood pressure more than 110, really no reason to not give the therapy. Again, nobody's giving the therapy, so it's not, we use blood pressure as an excuse. We use hyperkalemia as an excuse. Well, we have potassium binders, you can optimize therapy. Nobody's using this. So there's a big problem, in my opinion, in academia, that we have become so cynical and so critical that we constantly just argue every minutiae. I mean, no matter what trial comes out, I don't know how many of you are on Twitter. You have a COAPT trial. I mean, what a beautiful trial with beautiful results, and the Twitter is just lit up with criticism. So remember that there's a lot of philosophical literature that the big truth is unknowable. Now, this is not the topic that you should be talking about when you're 4 minutes over time anyways, about whether the big truth is knowable or not. The point that I'm trying to make here is that at some point, even if you don't have every single answer, and you're sitting with the patient right in front, the question is, who do you give benefit of the doubt? To patient or not? So if you have a patient, if you have a drug, so HFrEF and Paradigm, for instance. So everybody's saying, well, nuance at heart failure, I can't give it because there's no data. Of course there's no data, right? I think it will be a stretch if you say that I'm going to give Entresto to HFpEF. We really need to wait for the trial. But nuance at heart failure with low ejection fraction, do we really need another trial once we have understood the biology? So my only argument is that at least in my practice, I would much rather give the benefit of the doubt to the patient and not become so cynical and so skeptic that we don't use these potent therapies. I will stop here, and I very much appreciate all the attention and the invitation, and happy to take questions. Thank you.